Good morning. I'm Dr. Esha Nagpal, professor in the Department of Orthodontics. I'll be taking a presentation on retention in orthodontics. So, uncertainty is the only certainty. Orthodontic retention is the most uncertain part of the treatment. According to Angle, the problem involved in retention is so great as to test the utmost skill of the most competent orthodontist, often being greater than the difficulties encountered in the treatment itself. So what is retention? It is the holding of teeth following orthodontic treatment in the treated positions for the period of time necessary for maintenance of results. Riedel gave another definition, that the holding of teeth in the ideal aesthetic and functional position, and relapse is defined as changes in tooth position after orthodontic treatment. According to Hickson and Horowitz, there are three proposed divisions of relapse. The first is physiological recovery. The post-treatment changes that represent a rebound towards the original malocclusion, that is a change in the original physiological state, that is the cause of relapse. Second part is the developmental changes that are anticipated as part of development without intervention of treatment. And relapse is also due to improper treatment, inadequate mechanics, or poor patient cooperation. Now there are 9 theorems of retention and relapse given by Riedel in 1960. Theorem 1, teeth that have been moved tend to return to their former positions. This is mostly true for rotations. Theorem 2, elimination of the cause of malocclusion will prevent recurrence. Many causes of malocclusion are known to cause recurrence, especially habits like tongue thrusting, thumb sucking. Theorem 3, malocclusion should be overcorrected as a safety factor. There is no data to support this, but it is usually followed. Theorem 4, proper occlusion is the potent factor to hold teeth in their corrected positions. Theorem 5 is bone and adjacent tissues must be allowed to reorganize around the newly positioned teeth. 6th theorem is that if the lower incisors are placed upright over the basal bone, they are more likely to remain in good alignment. Theorem 7, correction carried out during periods of growth are less likely to relapse. Theorem 8, the farther the teeth have been moved, the less is the likelihood of relapse. There is little evidence to support this treatment. Theorem 9, arch form, especially the mandibular arch, cannot be altered permanently by appliance therapy. And the 10th theorem, which was given by Moyers, is that some malocclusions require permanent retention. Now, to study relapse, 4 schools of thoughts were given by various scientists. These are occlusal school, apical base school, mandibular incisor school, and musculature school. So coming to the occlusal school, which was given by Kinsley in 1880, he stated that occlusion of teeth is the most important factor to determine stability in new position. The apical base school, given by Lundstrom in 1925, was suggested that apical base is one of the most important factors, and intercanine and intermolar width should be maintained as originally present in the jaw. Nance in 1947 said that arch length may be permanently increased to a very limited extent. The mandibular incisor school was given by Grieve in 1944, and Tweed redefined it in 1954 and suggested that the mandibular incisors should be kept upright over the basal bone. And the musculature school, which was given by Rogers in 1951, he said that there is a necessity to establish proper functional balance to prevent relapse. Now, what is the necessity for retention, or what is the main problem when it comes to retention of results? According to Profit, 3 major reasons are the gingival and periodontal tissues. Gingival and periodontal tissues are affected by orthodontic treatment. There are changes in gingival and periodontal tissues, and they need time to reorganize when the appliances are removed. Second factor that determines the need for retention is teeth are in an unstable position after treatment, and there are multiple soft tissue pressures in the mouth which cause increased chances of relapse. And changes produced by growth after treatment can alter orthodontic treatment result. Now, what is the biological basis of relapse? Studying it in further detail, relapse can be determined by or is caused by 2 main causes. One is post-treatment relapse, which is a very rapid relapse, and then there is post-retention relapse, that is a very slow relapse and is almost similar to aging, that this can happen maybe 10 to 15 years after the appliances are removed. Now, post-treatment relapse. Post-treatment relapse is determined by tissue response in the periodontium, tissue response in gingiva, and relapse at extraction site. So, coming to periodontal ligament. Now, tissue response in the PDL, orthodontic treatment causes widening of the PDL space and disruption of collagen fiber bundles that support these support the tooth. PDL reorganization is important to prevent relapse. What periodontal ligament fibers do is they bring about active stabilization of teeth and maintain the teeth in a state of equilibrium. This prevents cheek, tongue, lip pressures from affecting or causing movement of the teeth. But during orthodontic treatment, all the collagen fibers are disrupted and there is widening of the PDL space. This reduces the stabilization by PDL, and therefore as soon as the appliances are removed, unstable forces from the soft tissues in the mouth bring about movement of the teeth. Therefore, there is need for immediate insertion of a retention appliance. Now, gingival fibers. Gingival fibers are also disturbed by orthodontic tooth movement. So, these are elastic and collagen fibers. These fibers take much longer than the PDL fibers to reorganize. So, it has been said that the collagenous fiber network reorganizes within 6 months, but the elastic supracrustal fibers need at least 12 months for reorganizations. Therefore, the need for prolonged retention. Now, relapse at extraction site. Extraction site always has a tendency to reopen. We've always seen extraction spaces reopening, and this is due to invagination of the epithelium inside the connective tissue, and then there is production of, because of these invaginations, there is production of glycosaminoglycans which cause relapse of or opening up of extraction spaces. So, looking at the overall principles of retention, following points have been listed by Prophet. Teeth relapse in the direction of their original tooth position due to elastic recoil of gingival fibers and due to unbalanced soft tissue forces from tongue and lips. Teeth require full-time retention of about 3 to 4 months after the appliances are removed, and 12 months retention due to slow response of gingival fibers. So, to recapitulate, elastic recoil of gingival fibers, cheek, lip and tongue pressures, and differential jaw growth. These are the main factors which cause interarch irregularity and changes in the occlusal relationships once the appliances have been removed. Now, post-retention relapse. So, this was post-treatment relapse. Now, coming to the post-retention relapse, that is after about 2 years, once the retention appliances have been taken off by the patient, there continues to be some amount of relapse happening. Most studies show that 40 to 90% of patients have an unacceptable dental alignment 10 to 20 years after retention. Various causes have been listed. One is craniofacial growth, then dental development and muscle function. Now, growth, because of various studies conducted by scientists like Bjork, we have seen that facial morphology has 2 patterns of growth. One is forward or upward rotation and one is backward rotation. So, different kind of rotations in different individuals who have different growth patterns. Tendency of relapse also varies. In a forward and upward rotation pattern, there is more mesial directed force which tends to create or crowding or bunching up of lower anteriors. This is referred to as packing. So, in low angle cases, there is an anteriorly directed path of eruption than the normal individuals. Therefore, need for permanent retention of lower incisors increases. In case of backward rotation growth patterns, in individuals with longer faces or backward rotation of mandible, incisors tend to functionally relate with the upper incisors and they tend to be more retroclined. Therefore, alveolar prognathism is reduced. So, this is the difference in the growth pattern which can affect retention protocol. Now, dentofacial growth, when we see long-term retention, how does it affect the stability? Skeletal changes that occur during retention can exaggerate or maintain the dentoskeletal relationship. Therefore, retention devices should be chosen depending upon the dentofacial growth, not just follow one single protocol for every patient. So, since we see 2 types of growth rotations, forward or short faces and long faces, in short faces, there is a need for prolonged dentoalveolar decompensations, and anterior bite plane during retention phase could be needed until the growth is completed. Especially with long face syndrome cases, They may require a high pull face bow headgear to hold the position of molars and prevent further dentoalveolar downward growth or cause which can further worsen the physiognomy. Coming to the pubertal growth pattern. Normally we think that pubertal growth pattern is also similar in every kind of facial pattern, but pubertal growth spurt is seen to be shifted about 2 years later in a skeletal deep bite case than in an open bite case. Therefore, these patients require a longer retention period than the skeletal open bite subjects. Now coming to lower retention, we've always seen delayed lower incisor retention, delayed relapse in the lower incisors. So there are 6 treatment keys to eliminate lower retention. First is the incisor ledge of lower incisors should be on the apog line or 1 mm in front of it. Second key is that lower incisor apices should be spread distally than the crowns to facilitate retention this way, and the lower lateral incisors should be further distally angulated in the central incisors. The apex of the lower cuspid should be positioned distal to the crown. All 4 incisors including the apex must be in the same labiolingual plane. Lower incisor cuspid root apex should be positioned slightly buccal to the crown apex to prevent lingual relapse of the crown, and lower incisor should be slenderized to increase the contact area so that there is no slippage of contact. Now a brief about relapse after surgery. Stability after surgical repositioning depends upon direction of movement, types of fixation and surgical technique. Hierarchy of stability is the highly stable surgeries are superior positioning of maxilla, mandibular advancements less than 10 mm. Less stable are maxillary advancement less than 8 mm without any vertical component and maxillary asymmetry. Stable are maxillary if modified with rigid internal fixation or maxillary impaction and mandibular advancement, that is long pace, maxillary advancement plus mandibular setback, and problematic cases are mandibular setback, downward movement of maxilla, maxillary expansion. Maxillary expansion is the least stable of all surgical procedures because palatal mucosa is stretched and an elastic rebound causes relapse. Therefore, to conclude, we have to understand that in spite of intensive research that has happened, we are still ignorant about the factors that contribute to post-treatment change, and that is why advice that retention should be permanent is suggested. Thank you.